There's some interesting information in the book about congenital heart defects, and I am not really going to go into this much in this class because it's rare that you're seeing serious congenital heart defects in physical therapy. Usually those are dealt with right after birth, and surgical intervention is often the case. Minor congenital defects don't have very many symptoms usually. So we're going to go right into cardiac infections and vascular disease, which, another exciting area in the cardiovascular world. So inflammation and infection of the heart, and of course we know inflammation and infection are two different things, even though infection can cause inflammation. Rheumatic fever and rheumatic heart disease, rheumatic fever is an acute systemic inflammatory condition that's caused by an infection. And it may result from an abnormal immune reaction to the pathogen. So it usually occurs a few weeks after an untreated infection, usually a specific streptococcus infection. So it usually occurs in children between the ages of 5 and 15 years. And it's pretty infrequent these days because people are treated more frequently for strep infections. And they sort of nip it in the bud. It doesn't get to the rheumatic fever stage. However, it still remains a threat because there are new strains of streptococcus out there, including antibiotic-resistant strains, and that's where it could be a real problem. So maybe the child who has the strep is getting treated, but it's an antibiotic-resistant form of strep, and it develops into rheumatic fever before the antibiotics can kill it. So a lot of times it involves the heart as well as the joints, so that's why they call it rheumatic. The long-term effects can be rheumatic heart disease or even infective endocarditis and heart failure in older adults, and we'll talk about infective endocarditis as well. So the signs and symptoms are usually low-grade fever, leukocytosis, elevated white blood cell count, malaise, anorexia, fatigue, and tachycardia. For diagnostic tests, they do a heart function test. They do the EKG and antibody titers. They're seeing if you have antibodies to that particular pathogen. The treatment is they use antibacterial agents and anti-inflammatory agents. So this is sort of the flow chart for development of rheumatic fever and rheumatic heart disease. So you get that antecedent infection, so you get the strep infection, and normally you recover from it. So your body, however, has formed antibodies to that streptococcus, and you get an antibody reaction. This is an abnormal reaction to the antibody, which causes inflammation of the heart, joints, skin, and brain. That's never good. So you can get pericarditis, causing infusion because the pericardium is inflamed. You can get endocarditis, causing valve damage because the endocardium is inflamed. And you can get myocarditis, causing arrhythmias because it affects the heart muscle. So all three layers of the heart can be affected by rheumatic fever. So long-term scar tissue can develop, and you get loss of valve functions and arrhythmias, and that's when it turns to rheumatic heart disease. That loss of function is called rheumatic heart disease. So infective endocarditis, it's a bacterial infection of the endocardium, basically. It can subacute, which has an insidious onset, can be caused by a particular Streptococcus viridans. The acute stage is usually caused by Staphylococcus aureus, one of our not favorite bacteria. So those guys are natural, normal flora for our body, just getting in the wrong place at the wrong time. Um, the basic effects of the endocarditis are the same regardless of which organism is causing it. Um, Factors that can predispose someone to infection of the endocardium are abnormal heart valves, because there's some place for the bacteria to latch onto. Bacteremia, which is where the bacteria is in your bloodstream, so it's flowing through your heart. And reduced host defenses, so you have some kind of immunosuppression for whatever reason, and you can be more susceptible to endocarditis. So the symptoms are low-grade fever or fatigue, anorexia, splenomegaly, congestive heart failure in severe cases. The acute type is sudden marked onset with a fever spike, chills, and drowsiness. The subacute is the more insidious onset with increasing fatigue, loss of appetite, cough, dyspnea. They use a blood culture to identify the causative agent, and a lot of times they have to have IV antimicrobial drugs for several weeks. So they may need to be hospitalized for that, or they may need to go in every day for infusions. Usually they'll install a PICC line, so they're not stabbing you every day to do infusions, and they do the antibiotic infusions through the PICC. So pericarditis is usually secondary to another condition. It's classified by the type, the cause, or by the type of exudate. So acute pericarditis is inflammation to the pericardium. Might be secondary to open heart surgery, myocardial infarction, rheumatic fever, lupus, cancer, renal failure, trauma, or viral infection. So any of those things could cause inflammation of the pericardium. Effusion may develop, and this is a big problem. If you get a large volume of fluid accumulating in the pericardial sac, it damps the heart motion. It makes it harder. If it's a lot of it, it can be a real problem. It leads to distended neck veins, faint heart sounds because the heart's being damped, and pulsus paradoxus, which is where the pulse actually slows down when you would expect it to speed up because you're not getting as good oxygen diffusion. That's why they call it paradoxus, paradoxical pulse. You would expect it to speed up, but it actually slows down. So pericardial effusion, the fluid around the heart compresses the heart. The heart can't expand to fill. You get decreased blood flow to the lungs, back up into the systemic circulation, and decreased output to the body. So not a good thing. On to vascular disorders. Good old arterial disease, hypertension, very common. High blood pressure. It may occur in any age group, males or females. It's more common in individuals of African ancestry, but it's not uncommon in the general population. Sometimes they classify it as systolic or diastolic, meaning you have an elevated systolic or an elevated diastolic, but not both. Sometimes it's both. So the systolic pressure is measured when the heart contracts. The diastolic pressure is measured when the heart relaxes in between beats. So hypertension is when the pressure stays high even during when the heart relaxes. So diastolic hypertension tends to be genetic rather than caused by any other factor. Systolic, there can be a lot of different factors that can cause it. So primary or essential hypertension is where the blood pressure is consistently above 140/90 millimeters of mercury. That's the unit of measure. It may be adjusted for age. So as people get older, their blood pressure gets a little bit higher, and so if someone has like sort of what they call borderline high blood pressure, and they're an older person, they might say, well, that's to be expected at this age. So primary hypertension is caused by an increase in arteriolar vasoconstriction. So over a long period of time, it can cause damage to arterial walls because the blood supply in the involved area is reduced. You can get ischemia and necrosis of tissues with loss of function. So it's not good. Secondary hypertension can result from renal or endocrine disease, or like a benign tumor of the adrenal medulla can cause secondary hypertension. The underlying problem has to be treated in order to reduce the blood pressure. So malignant or resistant hypertension is uncontrollable, severe, and rapidly progressive form with lots of complications. A lot of times with malignant, the diastolic pressure is extremely high. So a lot of different things can cause hypertension to develop. If there's systemic vasoconstriction, it decreases the blood flow to the kidney, which increases renin secretion, which causes systemic vasoconstriction, and aldosterone secretion, which causes increased blood volume. The systemic vasoconstriction causes increased peripheral resistance. Both of those cause increased blood pressure. You can damage the retinal blood vessels, the arterial walls, the cerebral arteries, and the heart, and renal blood vessels, which then cause the whole cycle to go again. So diabetic problems can cause it, systemic problems can cause it, nephrosclerosis, which is hardening of the kidneys, can cause it. So there are a lot of things that can cause you to develop hypertension. And generally, it's primary or essential hypertension for most people that have it out there. And but this sequence of events happens with all of them. So the areas most frequently damaged by hypertension are kidneys, heart, brain, and the retinas. Predisposing factors are aging, which aging is better than the alternative, but that's all you can say about it, I guess. The incidence of high blood pressure increases with age. Men are affected more frequently and more severely, but the incidence in women increases after middle age. Genetic factors are large predisposing factors. Sodium intake, excessive alcohol intake, obesity, smoking, prolonged or recurrent stress. So here's another reason not to smoke. We could call this class A Million Reasons Not to Smoke. So the effects of uncontrolled hypertension, you could have a stroke. That's bad. The additional pressure and the pressure on the arteries can cause you to have that hemorrhagic stroke. You can have retinopathy just because of additional pressure on the arteries to the retina. You can have congestive heart failure, atherosclerosis, angina, or myocardial infarction. You could have hardening of the kidneys or chronic renal failure. So uncontrolled hypertension can wreck you. So it's easy to control for primary hypertension. So let's see how that's done. So hypertension is frequently asymptomatic in the early stages. So the initial signs are pretty vague and non-specific. Fatigue, malaise, and sometimes morning occipital headache. So back of your head. Essential hypertension is treated in steps. Usually they will ask you to make lifestyle changes, reduce your sodium intake, reduce your weight, reduce your stress, if that's possible. And then they will do diuretics, ACE inhibitors, or combinations of the two. So you can't change your age, you can't change your gender, you can't change your genetic contributions that your parents made, but you can change a lot of other things. And being on hypertensive medications, it's better than having a stroke. So that's my motto, is I'd rather take a pill than have a stroke. I'm going to get a shirt made that says that. Peripheral vascular disease, or atherosclerosis, is disease in arteries outside the heart. So we talked about it with regard to coronary arteries. When it's outside the heart, it's referred to as peripheral vascular disease. There's an increased incidence of peripheral vascular disease with diabetes. The most common sites are the abdominal aorta, the carotid arteries, and the femoral and iliac arteries. Blood flow is assessed by Doppler studies and arteriography. There is the procedure that I'm not going to pronounce that measures the size of limbs and blood volume in the organs or tissues, so that can tell whether you have narrowing of the arteries because you'll have less blood volume. So the signs and symptoms of peripheral vascular disease can be increasing fatigue and weakness in the legs, intermittent claudication, which is leg pain associated with exercise. It's caused by muscle ischemia because especially if you have it in the iliac or femoral artery, the blood flow can't keep up with the workload when you're exercising. Usually when you have that claudication, the leg pain caused by claudication, when you sit down and rest, it goes away. Sensory impairment can occur, tingling, burning, and numbness. Peripheral pulses distal to the occlusion become weak. So the appearance of the skin and feet and legs can change. Marked pallor or cyanosis, which is that blueness, the skin is dry and hairless, and the toenails become thick and hard. The treatment, you want to keep control of your diabetes, maintain control of that blood glucose level, reduce your BMI. These sound familiar, don't they? A lot of the cardiac treatments involve these same things. Reduce serum cholesterol, platelet inhibitors or anticoagulation medication, so those are like Plavix and Coumadin. Stop smoking. That one comes up a lot too. Increase activity and exercise. Hey, that's great. Send them to PT and we'll get them on a good exercise program. Maintain a dependent position for legs to improve arterial perfusion. Peripheral vasodilators. It's really important to observe the skin for breakdown and treat any skin breakdown signs promptly. That is one thing we can educate our patients on, how to look at their skin, use a mirror if they need to, especially when they have peripheral neuropathy. They might not be able to feel changes, but they can see them. So either they need to use a mirror to inspect their feet and legs or have somebody else do it. Because if skin breakdown isn't treated properly, gangrene can develop, and then you have to get amputations. And so a lot of people lose limbs because of peripheral vascular disease. So one of the nurses that I used to work with, she was an old school nurse. She said when she was first coming up in nursing, all the nurses smoked. She said they would sit at the nursing station and smoke while they did their charts in the hospital, which is mind-blowing in today's hospital. But she said that she was, when she was a little bit older, she was going into the doctor to get some test results. And when he went in there, he asked her, "Did you just smoke a cigarette when you were in the car?" And she's thinking, "Uh-oh, busted." And she said, "Yeah." And he says, "Well, I hope you enjoyed it because it's your last. You have peripheral vascular disease and you need to stop smoking right now." So that was her wake-up call, and she did. She stopped smoking right then. So I'm glad that nurses don't smoke at the nurses' station anymore. So aortic aneurysm, it's a localized dilation and weakening of the arterial wall, and it develops from a defect in the medial layer of the artery. So there are 3 different forms of it, and I have some pictures of them on the next slide. The saccular is a bulging wall on one side. That one can be dangerous because it's a place where a plaque can form. The fusiform, which the picture here shows a fusiform, it's a circumferential dilation along a section of the artery. So the shape is really similar to like a fusiform muscle, but it's that bulgy shape. A dissecting aneurysm develops when there's a tear in the tunica intima of the wall, and the blood continues to dissect or separate the tissues. So here's the three different types. Fusiform, it's the circumferential bulge. The saccular, a bulge on one side where a thrombus can form. And then where there's the tear in the intima and the blood flows between the layers of the wall and pulls them apart. That one can be really life-threatening. So it can be caused by atherosclerosis, it can be caused by trauma, syphilis and other infections, or congenital defects. So a lot of times bruit or like a gushing sound can be heard on auscultation. A pulse can be felt when they palpate the abdomen. And a lot of times they're asymptomatic, but they can become large or rupture. And rupture can lead to moderate bleeding, but it can also cause severe hemorrhage and death. So that's a big deal. I one time worked with a lady who had Marfan syndrome, which is a connective tissue disorder, and so that's a congenital defect. She had a spontaneous dissection of the of an aortic aneurysm is a potential problem with Marfan syndrome, and it happened to her while she was in the shower. She luckily got help right away, and she was airlifted to the hospital, and they did surgery, and it saved her life. So it could have been another story. Luckily, it was a good story, not a bad story. The diagnostic tests to test for aortic aneurysm are radiography, ultrasound, CT scans, and MRIs. You treat it by keeping blood pressure at normal levels so you're not putting pressure on that aneurysm. You want to prevent sudden elevations of blood pressure caused by exertion. So don't be picking up those heavy weights. You want to prevent stress, coughing, and constipation. And surgical repair is the treatment. So venous disorders, varicose veins are irregular dilated areas, tortuous areas of superficial veins. It's pretty much genetic. There's a familial tendency towards varicose veins. Increased BMI, parity, which is giving birth, and weightlifting are risks that can increase varicose veins. In the legs, they can develop from defects or weakness in the vein walls or valves, and they appear as irregular purplish bulging structures. So in the picture, you see the guy has the varicosities. Treatment: legs elevated, support stockings, avoid restricted clothing, and crossing the legs. Thrombophlebitis and phlebothrombosis, two different things. Thrombophlebitis is thrombus development in an inflamed vein, like an IV site or a surgical site. Phlebothrombosis, the thrombus forms spontaneously without prior inflammation, and it's attached loosely, so there's much more chance of it detaching and becoming an embolus. Factors for thrombus development are stasis of blood or sluggish blood flow, because when it's sluggish, it has time to sit around and clot. Endothelial injury, so like an IV site, or increased blood coagulability. So a lot of times they treat it with anticoagulants. Signs and symptoms often go unnoticed, but there can be aching, burning, or tenderness in the affected leg. Systemic signs include fever, malaise, and leukocytosis. So we've seen a lot of things where the signs are fever, malaise, and leukocytosis. So that just tells us there's a problem. It doesn't tell us what it is. We need further tests. The complication is a pulmonary embolism, because if that thrombus breaks off, now it's an embolism, it's loose in your system, and it can go up and cause problems in your lung, or it can be can end up in your brain too, which is never good. The treatment: preventative measures, exercise and elevating the legs, anticoagulant therapy, or possibly surgical intervention. Last thing we're going to talk about in this chapter is shock. So the the definition of shock is its inadequate perfusion of oxygenated blood. That's it. So lots of things can cause it. Hypovolemic shock is loss of circulating blood volume. So a big injury that causes you to lose a lot of blood, that's what causes hypovolemic shock. Cardiogenic shock, it's the inability of the heart to maintain cardiac output. So if you have a heart attack, that can cause cardiogenic shock, and it can cause you to faint, lose consciousness. Distributive, vasogenic, neurogenic, septic, and anaphylactic shock all cause changes in peripheral resistance leading to pooling of blood in the periphery. So all of those things have the same effect of causing shock. So this is a table from the book that shows the type of shocks, the mechanism, and the specific cause. So hypovolemic shock, you lose blood or plasma. So hemorrhage, burns, dehydration, peritonitis, where there's infection in the peritoneum, pancreatitis. So all those things can cause you to lose blood or plasma. Cardiogenic shock, decreased pumping capability of the heart. So it can be caused by MI of the left ventricle, cardiac arrhythmia, pulmonary embolus, cardiac tamponade. Vasogenic, which is neurogenic or distributive shock, is vasodilation owing to loss of sympathetic and vasomotor tone. So that can be pain or fear can cause you to go into shock. Spinal cord injury, that's the neurogenic shock. Hypoglycemia, which is insulin shock. Anaphylactic, it's systemic vasodilation and increased permeability because of a severe allergic reaction. That's the bee sting, medication reaction, nuts, shellfish type thing. That's the one you use the EpiPen for. Septic shock or endotoxic shock, it's vasodilation because you have severe infection, often with gram-negative bacteria. So those virulent microorganisms or multiple infections cause vasodilation and increased capillary permeability, and so that's what causes septic shock. So the early manifestations of shock are anxiety, raised heart rate, tachycardia, pallor, lightheadedness, syncope, which is fainting, sweating, and oliguria, which is decreased urinary output. And that's because of renal vasoconstriction and the renin mechanism. So the compensation mechanisms, the sympathetic nervous system and adrenal medulla are stimulated to increase the heart rate, increase the force of contraction, and systemic vasoconstriction. So a lot of those types of shock cause systemic vasodilation. The sympathetic effect causes systemic vasoconstriction to fight against that. The renin secretion increases, and that's to increase your blood volume and hopefully increase the oxygen that's traveling in there. Of course, if it's cardiogenic shock, that's probably not going to happen. Increased antidiuretic hormone secretion, and again, that's to keep your blood volume up. Secretion of glucocorticoids to decrease inflammation. Acidosis stimulates increased respiration, but with prolonged shock, the cellular metabolism is diminished, and because the waste aren't removed, that leads to lower pH, and that gives you acidosis again. So prolonged shock can be a really serious problem. You definitely want to deal with the repercussions of shock as soon as you can. Complications of shock can be acute renal failure because of the effects on the renal system, shock lung, as they call it, or adult respiratory distress syndrome, hepatic or liver failure, paralytic ileus stress or hemorrhagic ulcers, infection or septicemia, disseminated intravascular coagulation. That's where you can't control the coagulation or decoagulation of your blood, that's very serious, or depression of cardiac function, which is also very serious. So shock can be a life-threatening thing if it's not dealt with. This is also from the book, Manifestations of Shock. Has the early signs, the compensation, and the progressive signs, and then what causes them. So the early signs are caused by sympathetic stimulation because of the hypotension. The compensation signs are caused by the sympathetic stimulation, peripheral vasoconstriction, renal vasoconstriction, the osmoreceptors stimulated, causing you to be more thirsty because you're trying to build your blood volume, and rapid respirations are caused by the increased lactic acid secretion from anaerobic metabolism, leading to the increased respiratory rate. So the progressive manifestations of shock are usually caused by the decreased blood flow and cardiac output and the anaerobic metabolism, and the decreased renal excretion. So it progresses to pretty serious stuff pretty quickly. So that's why shock is treated in the emergency setting pretty urgently. So this is just another graphic that shows the general effects of circulatory shock. So they're all bad things.